Bismillahirrahmanirrahim. Assalamu alaikum. Today we are going to discuss an important topic, that is the venous thromboembolism. Why we are discussing this topic in obstetrics? As we will discuss further in the lecture, the most important and crucial point is that pregnancy itself is a hypercoagulable state. And as we know from the knowledge of our medicine and surgery, that all the hypercoagulable states, irrespective of the etiological factors, can lead to venous thromboembolism. So, therefore, this is the reason behind that we have to have a thorough knowledge about the venous thromboembolism in pregnancy and how we are going to investigate and manage this condition. Venous thromboembolism is the most common cause of direct maternal death in UK. Whether we would say in the most European countries of the developed countries. Why we are not considering this as one of the most direct cause of direct maternal death in the subcontinent or in our third world areas? Because here, I think which we encounter most is the most common cause of direct maternal deaths seems to be antepartum hemorrhage and postpartum hemorrhage and anemia as the etiological. So therefore, although in our country or in our areas we not considered as one of the main leading causes of mortality and morbidity, but the other thing is that many cases do go unrecognized as well. So therefore, inshallah, today the knowledge we will share together, we will come across the ways and means where we will be better able to have the risk assessment of this condition, and thus we will try our best that inshallah in our clinical practice we are not going to miss it. Maternal mortality rate of about 1 per 100,000, which is quite twice in that of the next most common cause that we have in European countries, is about the gender. As I told you earlier, pregnancy is a hypercoagulable state. Because two main features, when we consider the thrombotic and the fibrinolytic systems. So you have to keep this in mind, that at stage of the thrombotic system, check करो किससे मिल रहा है एंट्री को, किसी एंट्री मिल रहा है of the thrombotic system and the fibrinolytic system. So, why we considered that the pregnancy is a hypercoagulable stage? Because Uh, let's see together about the thrombotic system and the fibrinolytic systems during and the changes they encountered in these systems in the pregnancy. So as we see and look around this Venn diagram, you see pregnancy, it's a state for stasis. Uh, I think you remembered your physiological changes in pregnancy. You have learned about them. It is a state of stasis because of the effect of progesterone and pregnancy hormones. The vessels in the lower limb especially and they are affected, and the blood circulation is a bit of on a side of stasis in the lower limbs especially. There is a risk of vessel wall injury, as well as there is hypercoagulability itself, as we would see together now in the fibrinolytic system. So all these three factors, again, I would like to emphasize the stasis, the vessel wall injury, and the hypercoagulability. They all lead to more of the risk of thrombosis. So don't forget these three major points. The pregnancy itself is a state for stasis, pooling of the blood in the lower limbs, the hypercoagulable state, and the vessel wall injury. So coming to the hypercoagulable state, why the pregnancy is hypercoagulable state? These are the two main factors you have to remember. This is very important, and these are the main, one of the main etiological factors behind. There is an increase in the clotting factors age 9 and 10 and fibrinogen levels. It happens so in the pregnancy. Why? This we will see why we need, why the nature has gifted with us with this mechanism during the pregnancy, that we are having more of the clotting factors age 9 and 10 and fibrinogen. As well, there is reduction in the protein C and antithrombin 3 concentration. These are both anticoagulant features, and there is reduction in that one. And these are both coagulant features. These are all the coagulant features. These are all the clotting factors which are promoting the thrombosis, which are promoting the coagulation, and these are the antithrombin. And there, thus we see that the antithrombin systems are being on the lowest level and are on the side of reduction, whereas the clotting factors are on the side of increasing levels. Why do you think so it has happened? Why the nature has altered that change in pregnancy? And the main reason which comes in our mind is that because we want to have lesser and lesser hemorrhage at the time of delivery and postpartum. So therefore the nature has blessed us with these mechanisms so that there would be more and more clotting factors and less of the anticoagulant factors. You can see there are activation of the procoagulant factors. We can see we have increased fibrinogen levels, factor 5, 7, 8, 9, and 10. Plasminogen and anticoagulant factors are decreasing, like antithrombin 3 and protein C and protein S. They are all decreasing. As well as there is also an increase in protein C resistance as well. Protein C resistance as well. And they all promote thus the coagulant pathways. They all promote coagulant pathways. And on the other hand, there is decreased fibrinolysis. There is decreased fibrinolysis, and thus anticoagulant is inhibited. So the net result of these changes is to reduce the likelihood of hemorrhage following delivery. This is the main aim behind all these changes, to reduce the likelihood of hemorrhage following delivery. So, what are the other physiological or systemic changes as we have seen in that Venn diagram of stasis as well? So, what are the changes which are leading to the stasis as well? These physiological changes predispose the women to thromboembolism, which are exacerbated by the venous stasis in the lower limb due to the weight of the gravid uterus as well. So, the stasis is reinforced due to the weight of the gravid uterus as well. in addition to the pregnancy hormones, as I told you. Also, because of the placement of the inferior vena cava and the pressure which is placed onto the inferior vena cava due to the gravid uterus in the late pregnancy, as well as immobility, and particularly in the purpurium. Uh, in addition, you will further study in the lectures, again in your lectures about the purpurium, that purpurium is the state which is the most hypercoagulable state, like even more than the pregnancy. So the hypercoagulable changes are much enhanced during the purpurium. This is again that for cost triad. If the hypercoagulability, as we have learned about it, stasis and the endothelial damage or the vessel wall damage. So what are the factors which can lead to further endothelial dysfunction if a lady had been a smoker? If there are hypertensive changes as well, as we know already from our knowledge of hypertension, that they cause endothelial dysfunction. Endothelial damage can also occur due to surgery or placement of catheters and trauma. In addition to the physiological changes of hypercoagulability, some of the people have hereditary changes as well, which further enhance the risk of hypercoagulability. Like if they are hereditary having factor 5 legend mutations, prothrombin G202110A mutations, and protein C and S deficiency as hereditary factor as well. So they will be reinforced in pregnancy by the changes of pregnancy also, and these people will have be on further and much more risk than their counterparts who are with the normal and physiological changes of pregnancy only. So these are the people with the hereditary changes which will be at much more risk, which will be at the higher risk as related to the people with having only the physiological changes of pregnancy. Similarly, with the um, malignancies, with the chemotherapy, obesity, the risk of hypercoagulability. These are all the conditions, as I discussed with you earlier, that all the hypercoagulable states are the risk for thrombosis. Stasis like in permeability, and they can also lead to vessel wall injury. So there is around a 6 to 10 fold increase in the risk of VTE compared to the non-pregnant state in pregnancy. This I have told you earlier. So you see how is the risk enhancement, even in a normal pregnancy without any other risk factors, compared to the non-pregnant state, there is about 6 to 10 fold rise. And without thromboprophylaxis, we have to suffer this. The incidence of non-fatal pulmonary embolism and deep vein thrombosis in pregnancy is about 1% in the developed countries, and at the time of delivery, it rises about to 1 to 2%. Is further increased following the emergency cesarean section. The same thing. So the risk factors for thromboembolic disease, the pregnancy itself, and in addition to this, if the lady has one or two or more of the risk factors, as we will discuss in the list, they are more prone to have, and they will be at much more risk for the thromboembolic disease. So this is how, if we have these risk factors in mind and we assess a pregnant lady keeping in view these risk factors, we would be better able to understand for that individual patient and that individual lady a risk for thromboembolic disease. If the maternal age is more than 35 years, if there was a previous or hereditary thrombophilia, and if there was obesity of around more than 80 kg, previous thromboembolism, severe smoking or malignancy. So they will be further or much increasing the risk of thromboembolic disease. Now, specific to pregnancy, what other risk factors we have to keep in mind? If there was multiple gestation, preeclampsia, as we discussed earlier, that in the hypertensive disease, there is more components of the short triad, grand multiparity, cesarean section, especially if emergency, damage to the pelvic veins, sepsis, and the prolonged bed rest. So they are all related to more risk of thromboembolic disease. Now, coming to the thrombophilias, the hereditary ones, some fibrin are disposed to thrombosis through changes in the coagulation fibrinolytic system that may be inherited or acquired. So it was not only the pregnancy itself, it was the inherited or acquired
thrombophilias, which further increase the risk. There is growing evidence that both heritable and acquired thrombophilias are associated with the range of adverse pregnancy outcomes, particularly recurrent fetal loss as well. So not only for the mother, but there is a risk of in the thrombophilia patients with thrombophilia, there is a more risk of recurrent fetal loss as well and miscarriages. So the hereditary thrombophilias, they can result from deficiencies of endogenous anticoagulants protein C, protein S, and antithrombin 3 levels, abnormalities of procoagulant factors, factor 5 leiden caused by a mutation in the factor 5 gene, procoagulant factors, if there is a mutation, so there will be more of the coagulation, and prothrombin mutation of G20210A. So these are the four categories, four features in these different components of the coagulation pathway of protein C, protein S, factor 5 leiden, and prothrombin mutations, which can lead to hereditary thrombophilias. Now, the acquired thrombophilia is the most commonly associated with antiphospholipid syndrome. This one is the acquired, although it is genetic inheritance with the chromosome change as well. AP is a combination of lupus with a history of recurrent miscarriage and or thrombosis. It may or more commonly may not be associated with other autoantibody disorders such as systemic lupus erythematosus. If thrombophilic disorders are taken together, more than 50% of women with pregnancy-related VTE will have a thrombophilia. So with this, what we understand is that the women, whenever you are assisting a woman in pregnancy with the thromboembolism and you come across, then definitely about 50% of this population would have a hereditary thrombophilia as well. So it means that a large proportion of hereditary thrombophilia, ladies with hereditary thrombophilias, can have thrombosis in pregnancy. So what does we conclude then? That definitely these ladies should have a prophylactic regime in pregnancy, in antenatal and the postpartum period to have to be prevented from a thrombotic event. So as we will discuss further in the lecture, that the hereditary thrombophilia, although with a greater risk of thrombosis in pregnancy, can be helped out, can be prevented with the prophylaxis. It is therefore vital that women with a history of thrombotic events are screened for thrombophilia and dealt with accordingly. So coming to the prophylaxis, the presence of thrombophilia with the history of thrombotic episode, it means that prophylaxis should be considered for pregnancy. So this is what the main thing. With the presence of thrombophilia and secondly with the history of a thrombotic event in the past. Both these risk factors prompt us for a prophylaxis in pregnancy. So how we are going to diagnose a case of acute venous thromboembolism? Clinical diagnosis of VT is unreliable. Therefore, women who are suspected of having a GVT or pulmonary embolism should be investigated promptly. So not only the clinical diagnosis, but investigation is equally important for the management. Now, for the deep vein thrombosis, now for the deep vein thrombosis, the commonest symptoms are pain in the calf with varying degrees of redness and swelling. So please don't forget these symptoms. Pain in the calf with redness or swelling. Women's legs are often swollen during pregnancy. Therefore, unilateral symptoms should ring the alarm bells. This is very important. So the unilateral symptoms should ring the alarm bells, specifically one leg, and especially the left leg is more prone. And second important thing is that not only in the later part of pregnancy, even deep vein thrombosis can appear in the earlier gestation as well. So be vigilant about it. So what are the signs we come across? The signs are few, except that often the cough is standard to gentle touch or it is red or swollen. It is mandatory to ask about symptoms of pulmonary embolisms, as a woman with pulmonary embolism might present initially with a DVT. So both you have to inquire about. Compression ultrasound has a high sensitivity and specificity in diagnosing the proximal thrombosis in the non-pregnant women and should be the first investigation used in a suspected DVT as well. So calf veins are often poorly visualized with compression. So for the pelvis, it is very good, but for the calf veins, they are a bit, and as it is more common in the pregnancy with the calf veins, so it is not of much help during pregnancy, but can be applied as well. However, it is known that a thrombus confined purely to the calf veins with no extension is very unlikely to give rise to pulmonary embolism. So this is also a very good and positive feature for us. So for the venography, if we come across venography, so that was about the compression ultrasound during the investigation. Now coming to the venography, it is invasive, requiring the injection of contrast media and the use of X-rays. It does, however, allow excellent visualization of the veins both below and above the knee. Now, coming to the pulmonary embolism, it is crucial to recognize pulmonary embolism as missing the diagnosis could have fatal implications. Now, how a patient with a pulmonary embolism can present? The most common presentation is of mild breathlessness or inspiratory chest pain in a woman who is not cyanosed for the mild reasons, but may be slightly tachycardic, more than 90 beats per minute with the mild pyrexia. So, what are the features which can come across with the pulmonary embolism? Mild breathlessness, inspiratory chest pain, slight tachycardia, and with a mild pyrexia. Really, the massive pulmonary embolism may present with sudden cardiorespiratory collapse. If pulmonary embolism is suspected, initial electrocardiography should be carried out. Chest X-rays should be done, and arterial blood gases should be performed to exclude other respiratory diagnoses. However, these investigations are insufficient on its own, and it may be sensible to investigate the lower limbs for evidence of DVT by ultrasound. If positive, treat with a presumptive diagnosis of pulmonary embolism. You should be more vigilant and for on extra we have to have the management for pulmonary embolism. So for the venous thrombosis, because of the hypercoagulable state, they're more symptom, pain, outpatient, diagnosis by CT or angiography, and the treatment with rigorous resuscitation, IV heparin anticoagulation, surgical exploration for the peritonitis, and long-term therapy with warfarin can be given. So if all the tests are normal, what we did? Ultrasound, then we did for the venographies, the blood gases, and so on. And still, the clinical suspicion remains. A ventilation perfusion VQ scan or CTPA, computed tomographic pulmonary angiogram, should be performed. In both cases, the radiation to the fetus is far below the threshold considered potentially dangerous to the fetus. Now, coming to the screening test. D-dimer is now commonly used as a screening test for thromboembolic disease in non-pregnant women in whom it has a high negative predictive value. With pregnancy, a low level of D-dimer suggests the absence of a DVT or PE. So therefore, it has a good negative predictive value, and no further objective tests are thus necessary. And increased levels of D-dimer suggest that thrombosis may be present, and an objective diagnostic test for DVT and or PE should be performed. In pregnancy, D-dimers can be elevated due to the physiological changes in the coagulation system, limiting its clinical usefulness as a screening test in this situation. But even then, as I told you before, it is a good negative predictive value. Now, this is very important. important, how we are doing the obstetric thromboprophylaxis and risk assessment and management. So how we are carrying out the obstetric thromboprophylaxis, its risk assessment and management. Now, single previous venous thromboembolism event. If there was a single previous venous thromboembolism, plus there was thrombophilia or the family history, there was unprovoked estrogen related. Now, previous venous thromboembolism, a single previous venous thromboembolic event, plus there was a thrombophilia and a family history, and that was unprovoked, even it was not estrogen related, then previous recurrent venous thromboembolism were more than once, then we consider it as high risk. A patient which has a previous event and plus the family history, such a patient would be considered as a high risk. And what they require in their management, it will be an antenatal prophylaxis with low molecular weight heparin, and refer to the trustworthy thrombosis in the pregnancy expert team. Now, what of the ladies would fall into the intermediate risk? The single previous VTE has no history of thrombophilia itself. So, but there are medical comorbidities like the patient has accompanying heart or lung disease, SLE, animal malignancy, inflammatory conditions, nephrotic syndrome, or any surgical procedure has been done. So there was a previous event and now there is some comorbid condition as well. Then these patients would fall into the intermediate risk, and we need consider to have an antenatal prophylaxis with low molecular heparin, and we need to have a good multidisciplinary approach as well. Now, coming to the other risk factors which we consider, like if the age is more than 35, obesity more than 30, with the BMI, parity more than 3, smoker, gross varicose veins, current systemic infection, immobility, preeclampsia, dehydration, hyperemesis, multiple pregnancy. If two, three or more of the risk factors are there, these are the risk factors all we consider. Combining these three or more are there, we would fall, let have her into the intermediate risk. Then, if there are two or more, then we keep her admitted, and if there are less than three, then we consider them into the low risk. So if three or around two, they would be considered as intermediate risk, and they would be needing even in antenatal period the prophylaxis also. And if less than three, they will be in the low risk, and they would not be needing the lower molecular weight heparin, but only mobilization and avoidance of dehydration. This would be important. So now for the treatment of venous thromboembolism, warfarin was previously used, but now we have come across that it crosses the placenta and cause limb and facial defects in the first trimester in the fetus, as well as into several hemorrhages. So therefore, they are not used in pregnancy, and the preferred choice is always now low molecular weight heparin. Uh, the mechanical head valve replaced if the pregnant ladies are there. So in the postpartum period, they can be continued along with the heparin as well. Low molecular weight heparin are now the treatment of choice. They do not cross the placenta and have been shown to be at least as safe and effective as unfractionated heparin in the treatment of venous thromboembolism, with lower and fewer hemorrhagic complications in the initial treatment of non-pregnant subjects. In addition, low molecular weight heparin is safe and easy to administer, and women are taught to inject themselves and can continue this on their own for the duration of their pregnancy. They can be continued following delivery as well in the high risk patients, and women can choose to convert to warfarin with the need for stabilization of the doses initially and frequent checks of the INR, or remain on the low molecular weight heparin. So for warfarin, they have to adjust their doses according to the INR. Both warfarin and low molecular weight heparin are safe in women who are breastfeeding. So for the newer anticoagulants, they are direct factor 10 inhibitors, but they are not licensed for use in pregnancy, and their experience is limited. Now, coming to the graduated elastic stockings, they should be used for initial treatment of deep vein thrombosis. Thus, we are providing uh, and preventing the stasis of the blood into the lower limbs. And it should be worn for 2 years following a DVT to prevent post-thrombotic syndromes as well. Now, again, coming to the risk scoring. You see, if there is a previous VTE with unprovoked estrogen-related event, then they are of high risk. They have score of 3. Previous VTE provoked because of surgery, because of immobility. For the time being, it happened, so it was a of lesser risk. If there is family history of VTE, risk is 1, but not for the patient itself. Known thrombophilia 2 and medical comorbidities 2. And as we discussed earlier, for the age more than 35 years, obesity, parity, multiparas, smokers, and gross varicose veins, they have all much more risk. On the other hand, preeclampsia, if the patient has been suffering with hypertensive diseases, dehydration, ovarian hyperstimulation syndromes, multiple pregnancy resulting from, especially from artificial reproductive techniques, emergency cesarean section in labor, this definitely has a greater risk. And elective cesarean sections, mid cavity, forceps, or any instrumental delivery if it was carried out, because here we are at more risk of damage to the pelvic vessels, prolonged labor more than 24 hours, postpartum hemorrhage if it had happened. They're all the risk factors for uh, thrombosis. Any surgery, recurrent infections, and immobility. So this is how you uh, first you recognize the risks, and then you are going to score them. And thus, if we come across, if the score is 3 or more, then we are giving a low molecular weight happen in the antenatal as well in the postnatal periods, and even continuing for the 6 weeks. If the score is around 2, then outpatient management is done, mobilization, avoid dehydration, thus the stasis can be prevented, be vigilant with the regular follow-ups, and the postnatal low molecular weight happen for 7 days. If around 1 or more, then only the mobilization and avoidance of dehydration would suffice. So, for the venous thromboembolism prevention, what we can do and what we can guide in the antenatal period as well, even with the family history of the people, or with the ones who had previous unprovoked events in the before pregnancy, even we can guide them in the prenatal period as well, with the pre-pregnancy counseling as well. And what we can guide them is that exercise regime to increase the mobility and prevent stasis. Compression stockings and devices should be helped out with. Weight control is very important, because as we discussed and we saw among the list of risk factor, obesity definitely is a modifiable risk factor. Dehydration prevention, cardiac, if there is any accompanying cardiac comorbidity, it should be management should be carried out. Aspirin or anticoagulation prophylaxis for long carriers, uh, or for the car riders and aeroplane flights in pregnancy and surgery should be helped out. Aspirin anticoagulation while in the immunodeficiency states, they should be given. Avoidance of medication that increase the risk of venous thromboembolism, like contraceptives, they should be prevented. Now, again, this is very important that we are knowing about the very high, and the intermediate risk patients which we come across. So for the very high risk, previous VTE on long-term warfarin. If a lady had a previous venous thromboembolic effect and is already on the long-term warfarin, then what we do is that we recommend antenatal high dose low molecular weight heparin and at least 6 weeks postnatal low molecular weight heparin as well. So one of the candidates would be the one with the previous venous thromboembolism on long-term warfarin. Similarly, the patients, as we discussed about the hereditary thrombophilias, if they are already diagnosed with antithrombin deficiency, they would also be recommended the same management. Patients with having a phospholipid syndrome or previous venous thromboembolism would be the high risk for the medium risk. High risk or the medium risk. But the one with previous VTE as well, they would be on the very high risk category, that they had a fatty phospholipid syndrome. It had been in uncontrolled state somewhere, and they suffered from venous thromboembolism. So these patients would not only be having antenatal high dose low molecular heparin, but at least 6 weeks postpartum as well. Similarly, in the high risk group, we have the ladies with the previous recurrent and estrogen provoked, like pill or pregnancy, or unprovoked VTE. Like previous recurrent events were there, either they were estrogen provoked or unprovoked even. So, but they were recurrent VTEs. Then even single event which was estrogen provoked or unprovoked multiple events, they all fall into the high risk groups. Previous VTE was there, but there is family history as well, thrombophilia as well. Now you see, this is quite similar to the one this, no? Here and this one. But you see, in the very high script, the patient is already on long-term warfarin. Here only the thrombophilia is known, and here the type is known as antithrombin deficiency. The one, the patient suffering with thrombophilia specifically due to antithrombin deficiency would be in the very high group. So previous VTE, but not itself a patient of thrombophilia, but with a family history. Similarly, asymptomatic thrombophilia, although known that with asymptomatic and there was no previous VTE, then in all these cases also we recommend antenatal but not the high dose, intermediate doses, and at least 6 weeks postnatal prophylactic low molecular weight heparin. Here, it's not the prophylactic one, these were the high doses. These were the high doses, so you can see the difference now. Now, coming to the intermediate group, single previous VTE associated with transient risk factor. It was not a permanent risk factor, it was a transient factor which is no longer present. There was no previous history of thrombophilia, family history, or other risk factors. These will be falling into the intermediate group. A single previous VTE associated episode, and with other no other risk factors is any longer now prevailing. Similarly, asymptomatic thrombophilias accept antithrombin and combined defects or homozygous factor V laden deficiencies. So because antithrombin, the one with thrombophilias of antithrombin, they are of high risk group. We consider antenatal low molecular weight heparin but not routinely recommended. We consider antenatal low molecular weight heparin but not routinely recommended. With a single episode, with the asymptomatic thrombophilias, we do consider but not routinely recommended. Recommend 6 weeks postnatal. We are more and more worried for the postnatal period. The postnatal period is even 5 times more than that of the any stage of or any part of the uh, uh, event in the uh, life of a in the patient where we are expecting to have the thrombosis. So the highest, the period which falls of the highest risk is of the postpartum period. So therefore, we recommend 6 weeks postnatal prophylaxis in the low with the low molecular weight heparin. With asymptomatic one, where antithrombin deficiency and combined defects, and they have been ruled out, then we recommend only around like for 7 days. And for 6 years of the family history or other risk factors, and the post prophylaxis with the low molecular weight heparin. So it's about single unprovoked event and what we were doing about it, and the postpartum as well. Specifically, now I would like to tell you about also the women with the APLS. Women with clinical and laboratory criteria of antiphospholipid syndrome, not on long-term anticoagulants, for which what we should do. They have a clinical or laboratory criteria, but they were not previously taking any anticoagulation. Women with clinical and laboratory criteria with APS, not on long-term anticoagulation, and they need postpartum prophylaxis. And asymptomatic women with confirmed high risk profile, triple positive APLS, they also need postpartum. But with clinical and laboratory criteria for APS, they were not on the long term anticoagulation, but they need uh, antepartum prophylaxis as well as postpartum as well. This is very important. And as I discussed with you, with antithrombin, they are at high risk and they need at antepartum as well. But with protein C and S and positive family history, they need only postpartum. So antithrombin, the thrombophilias of antithrombin would be of higher risk group as compared to the thrombophilias resulting from protein C or S deficiency. Now, what is the low molecular weight heparin which we are using and how we do use it? In the early pregnancy, we can use it weight in kg, considering the weight in kg. So the initial doses are around less than 50, then 50 to 69, 70 to 89, and 90. So, like if it is 50 mg, less than 50 mg, we can give 40 mg VT. But in clinical practice, we are using around even less than for the less than 50 kg weight, we can here using about 40 mg once a day as well. But with a higher group, these are of the more you can say more consciously given dosages. But in the clinical practice where other risk factors are not present, we are giving 40 mg once a day. And for the higher weights, like about 90 and 100 kg, we are giving the BD regime also. And for the around 60, 70 to 80 kg, we can give 60 mg initially once a day as well. So enoxaparin is the one which is most commonly used, and these are given sub-Q in the skin. Subcutaneous injections are given. Deltaparin, tenazaparin, they are all used, and one of the regime is even for tenazaparin, 175 units per kg once daily. So these are all the doses which we should and the low molecular weight heparins and their evaluation, which should be in our mind while we are planning and we are treating the patients with venous thromboembolism, and where we are assessing their risk as well. So your risk, proper risk assessment and evaluation will definitely reduce the risk of comorbidities and reduce the risk of fatal implications of thromboembolism in these patients. Therefore, what I tried to together in our lecture was that keeping in view this risk factor of stasis, vessel wall injury, hypercoagulability, and all the factors leading to these conditions like that of stasis, vessel wall injury, and hypercoagulability should be dealt with stage by stage, should be assessed stage by stage, thus to reduce the risk of this very serious condition. So, and especially venous thromboembolism today we specially discussed, and it's more severe condition that of pulmonary embolism, which can be fatal, and which is an obstetric emergency, is can be prevented with our proper management of venous thromboembolism, because venous thromboembolism is definitely the precursor for the pulmonary embolus as well. So until unless initially we, if, as and how vigilant we are to assess this condition, we would definitely be able to manage the or prevent this catastrophic event of pulmonary embolism to happen. Pulmonary embolism, as we would discuss further in the obstetric emergencies, is a medical emergency, an obstetric emergency where oxygen supplementation, steroids, even intubation for the patient, and can be required for a revival. So these should be dealt with anticoagulants, antibiotics, and definitely the investigations of CT, PA, and VQ scans. So because this is a life endangering situation where we need to have abrupt and prompt response in cases of pulmonary embolism. So to prevent these conditions to happen, we definitely should have long term and pre-hand diagnosis and evaluation of venous thromboembolism. So always keep this feature in your mind as well, regarding keeping in view the physiological states of pregnancy, also about the thrombotic and the fibrinolytic systems also. Thank you very much for your kind attention. Hope you have gathered a good view and a good knowledge about the venous thromboembolism, which we can encounter in states of pregnancy. Thank you very much.